we realized during this pandemic, we were investigating a lot of outbreaks, but the two databases actually don't speak to each other. We started to reach out to our central office partners, so at the state level, to try to work with some of the database people instead of creating another database, saying, is there a way that we can align these two a little better? So our laboratory results, can we kind of merge that into the outbreak system so I don't have to manually enter it?
When there is no data standard as how frequently they have to report to CMS or to ICAP, they would report once every 2 weeks or so. Every 15th of every month, they would report once a month. And these kinds of data delays affected us a lot starting in October. And then it didn't really help when the surge started happening in November. On Thanksgiving weekend, for a week or so, the NHSN servers were down. So none of the labs were being reported to NHSN, and nor state or us could verify the labs from these long-term care facilities. When other sources of data was not available or reliable, I would say, we had to rely on other methods to verify the results if they came from a long-term care facility. And those are some of those, especially the resident side of data. We had to wrestle the data a little bit to get a much more quicker response so that we can control the outbreaks.
We did quickly become aware how dependent we are on the state and on NHSN at CDC when it stopped working. I think we got into a pretty good rhythm, and then it stopped, probably the worst particular time. I do credit Raju in creating a query really quickly in order to not have to manually go through every positive lab. We were monitoring that on a daily basis and watching the numbers rise, and the biggest limitation even with that is that's purely the residents. And what we've learned is they were kind of sitting ducks, and it was being introduced first, obviously, by the staff who live out in the community where it was going. So I think the team did a good job trying to address that in the middle of a lot of things going on, but it was still really challenging.
For the data piece, again, because I don't own it, it has taken a little bit of a while, and it's something that we're still continuing to work on, but I can start to see some changes. Slowly, things have been rolled out, and that's been really exciting. Oh, other epidemiologists are happy about this change. Data-wise, maybe I wish I had started earlier. It is a very slow process, especially with something that I don't own.
Data is just one aspect of it, right? Whether data or not, we want to protect the individual in the facility. That was our main critical factor rather than how quickly we were receiving the data. Yes, the more real-time data, it definitely helps. Yesterday, we only have one case, but how come there are 5 cases in this facility today? But if they're reporting once every 15 days, we had to pass, who is the index case? And by the time 15 days later, most of them will be out of quarantine, and we missed a big outbreak situation.
Asking for help and not being afraid to ask your administration or your higher ups for some assistance. This is what I'm doing. How can I get more staffing? Have that cross training of people within your health department. I think me being able to learn what others do, but also people being able to learn what I do has been so beneficial.
Resident data we will get, right? Eventually the lab will come, and then you can identify one way or the other, depending on the type of test they're doing. But what we can't know is the staff positives. That is very critical. And attrition rates in these facilities is very high. If an employer is confident and trust in our public health system, and they contact us and say, yes, we have a staff positive, and this person came in contact with these 3 individuals yesterday when he was symptomatic or something, maybe we can build a better system for the future, I guess.